Bismillah ar-Rahman ar-Rahim. This is Dr. Mervat Aboulmaaty, Professor of Cardiology and Consultant Electrophysiology at Ain Shams University. I'm the President of the Egyptian Cardiac Rhythm Association, which is a branch of the Egyptian Society of Cardiology. I'm going to give new insights into treatment of AF as two parts. This is the first part, and the second part will be a separate part with live in a box cases of RF ablation and cryoablation. AF ablation is a teamwork, never alone. You never do it alone. You have to have your team of doctors, technicians, and efficient nurses. I'm going to have my agenda with you about the introduction of AF and its mechanism, the novel investigations to assess the left atrium, the new approach to manage AF, how to prevent AF ablation by different techniques, MACE procedure, and left atrial occlusion. Mechanism of AF. The very simple mechanism of AF, as I used to teach it 20 years ago, the focal activation, which is initiating foci from within the pulmonary vein ostia, and these wavelets will perpetuate into fibrillatory conduction within the atrium. The multiple wavelet re-entry is the wavelets randomly entering tissues previously activated, and so forth. Here is the foci within the pulmonary veins, and here the sleeves of the myocardial sleeves. These are the muscle fibers from the posterior wall of the left atrium extending into the upper part of the pulmonary vein. And these myocardial sleeves have different refractory period between it and the other musculature of the posterior wall of the left atrium. The foci originate from within the junction of the pulmonary vein and the left atrium, and this is called the myocardial sleeve. These firing foci can go, this is the focal, and then make other foci into the left atrium, perpetuating as AF. Here is the musculature of the posterior wall of the left atrium, which was explained at Hadassah University in Israel in 1966. The posterior wall musculature is complex one, and the muscle fibers extends as sleeves around the four pulmonary veins, with more fibers around the superior veins than the inferior veins. There are different patterns, and there are different locations. What is the function of these myocardial sleeves? The myocardial sleeves prevent reflux of blood during atrial systole. They cause milking of blood into the left atrium, and they are the first part of the left atrium to contract, and they regulate the pulmonary flow. The newest mechanism of AF includes the anatomical re-entry within areas of scars, functional re-entry, and the rotor, which is the focal sources perpetuating into the left atrium as mother waves and daughter waves. There is enhanced automaticity with delayed after depolarization and early after polarization of the atrium. Here is the multiple wave re-entry foci. This is the focal one, firing foci from the left atrium, invading the left atrium and the other chamber, the right one, the multifocal, and the rotors. The foci of the left atrium are mainly concentrated into the upper pulmonary veins, the left superior pulmonary vein and the right superior pulmonary vein, and lesser foci into the left inferior and right inferior. There are other foci within the septum, with the superior vena cava, and within the coronary sinus and the ligament of Marshall. What is AF? The classification of AF in patients, the clinical classification includes the duration of AF, which is recorded in each patient. Paroxysmal AF is a self-terminating atrial fibrillation. In most cases, it terminates in 48 hours. Most of AF paroxysm may continue up to 7 days. So any AF terminating in less than 7 days, this is paroxysmal AF. The persistent AF is the AF that lasts longer than 7 days, including episodes that terminated after 7 days by cardioversion or by drugs. The long-standing persistent AF is the continuous AF lasting more than 1 year, and when you decide, you and the patient, to go back to sinus rhythm and for rhythm control. Permanent AF is the AF lasting more than 12 months, when you reach to a consensus between you and the patient that this is his current rhythm. So you will tell the patient, don't think about resumption of sinus rhythm. Permanent AF, atrial fibrillation, is your current rhythm. Non-valvular AF is AF in absence of rheumatic mitral stenosis, mechanical bioprosthetic heart valves, or mitral valve repair. Lone atrial fibrillation is the atrial fibrillation which occurs in patients mostly less than 60 years with clinical and echocardiographic absence of any structural abnormality. And these patients, of course, the lone AF have the best outcome in ablation and regarding thromboembolism. What is the definition of atrial cardiomyopathy? Atrial cardiomyopathy is a terminology which explains mostly what happens during atrial fibrillation. Atrial cardiomyopathy is any complex structural or architecture or contractile or electrophysiological changes. These changes affect the atria with the potential to produce clinically relevant manifestation. Atrial cardiomyopathy starts by includes fibrosis, electrical dysfunction, mechanical dysfunction, including procoagulant state. So fibrosis, electrical dysfunction, mechanical dysfunction, procoagulant state. What are the predisposing to this? Risk factors, genetic factors, cardiac diseases, and non-cardiac diseases. All this will cause the cardiovascular remodeling and will induce atrial cardiomyopathy. From the histopathological point of view, atrial cardiomyopathy has 4 types. Cardiomyocyte dependent, and this is what happens in lone AF and genetic diseases, diabetes mellitus, and this is class 1. Primary fibroblastic dependent, and this is class 2, and this is what we see in aging and during cigarette smoking. Mixed type of cardiomyocyte and fibroblast dependent, and this is class 3, and this is noticed in congestive heart failure and valvular diseases. Non-collagen deposit class 4, and this is a rare one which we see in isolated atrial amyloidosis, granulomatosis, inflammatory diseases, and other metabolic affection. In order to investigate the left atrium, we have novel investigation. But which type to investigate? We have to investigate the structural abnormality, the contractile, and the electrical abnormality which happens. For the structural abnormality, which is the fibrosis, the anisotropy, and the connection, then here comes the role of cardiac magnetic resonance imaging with the late gadolinium enhancement, and in order to check for fibrosis. For the contractile part of the function of the left atrium, here comes the echocardiography to detect the anatomy, the volumes, and the function of the atrium. And when we want to see the electrical remodeling, comes the electrical mapping, the voltage mapping, the electroanatomical mapping, and the electrical signals. We will see together the new approaches to the imaging of atrial fibrillation, starting with the simple one, the echocardiography and Doppler. 2D echo can measure the atrial volume, which is now the measure to assess the left atrial size. The left atrial volume taken in the 4-chamber view. We can also measure the right atrial volume. Doppler imaging with transesophageal echo can check the flow in the left atrial appendage and the function of the left atrial appendage. Here, transesophageal echocardiography has very important role with us because it can detect, as we can see in the lower panel, the thrombus in the left atrial appendage. It can check also the velocity and the function of the appendage. 4D echo also can make very good reconstruction of the left atrium and can be used to differentiate between pectinate muscle and thrombi. Here is a clear left atrial appendage for transesophageal echo. This is very good. This is very important for us before ablation of PVI or going into the transeptal to the left atrium, and also for anticoagulation before cardioversion. Here is the left atrial strain, the tissue Doppler, which has a very important role to check for left atrial function. And you see here on the left side, this is the left atrial strain in normal sinus rhythm, 80%. And on the right side, the left atrial strain pattern in AF is dropped, as you can compare between both pictures. Cardiac magnetic resonance is of utmost importance to check the extent of fibrosis in the left atrial especially the posterior wall, which is an important part during ablation of AF. The blue bar is the healthy tissue, and the white-green one are the fibrotic ones. Utah University classified the amount of fibrosis in the left atrium as stages 1, 2, 3, and 4. And this we can see the healthy one is the blue one, the stage 1. The extensive fibrosis one is the stage 4, and in between stage 2 and 3. Here comes my favorite, which is the electroanatomical 3D mapping. And here is the marvelous CAR2 system. And we are using, as you see, this roving catheter, multipolar catheter, lasso nav, which can get signals, these signals can be translated into voltage. These are mapping of the left veins, as you can see in the colors. The color code is the pink is the healthy tissue, and going to the green, yellow is the diseased one, fibrosed one. And you can see the electrical signal running down. Here, the same catheter going to the right-sided pulmonary veins, gaining signals, as you see the white dots on the roving catheter, to get signals and to map and to get healthy tissues and diseased one, as you can see here. Then we can get the anterior wall of the left atrium by the same catheter, the pink, good one, nice one without any scar, and the posterior wall, which shows some areas of scarring, the green and yellow colors. Then the roving catheter, the circular catheter, can check the potential. What are these potentials? These are the muscle fibers, as I told you in the beginning, with the muscle sleeves around the pulmonary vein, and we can see good picture of it. This is the spiky potential. These are the pulmonary vein potential, and this is what we isolate from the atrium, PVP isolation, pulmonary vein potentials. Here we can see, after we make the voltage map, we can translate it into anatomical map. This is why it's all gray. And then the red dots and the pink dots are the ablation points, which can run around the veins in order to isolate these myocardial sleeves from the left atrium and to isolate these foci. For AF management, and after investigation, now we will go to the management, treatment. First, primary prevention. You have to prevent AF by risk factor modification, by ideal body weight target, by treatment of hypertension, treatment of diabetes, cessation of smoking. All these measures can prevent the occurrence of AF. Primary prevention, you prevent the risk factors which precipitate to the factors which goes into AF. And second prevention is that when you have these diseases, you have to minimize them, like stopping smoking, treatment of heart failure, treatment of hypertension, obesity, obstructive sleep apnea, and so forth. Then we have to manage the AF by rhythm control, rate control, and stroke prevention. And we have a very important role for the society, for awareness. And we have the Apple Watch, and we have the, which can check and make alarm to patients, to people, if they get high heart rate or irregular heart rate, to make them go and check themselves. I will concentrate now with the prevention of AF, because prevention is better than treatment. Prevention of three types. The primary prevention, we know, the secondary prevention, complication, and primordial prevention of the factors which precipitate to AF from the beginning. But what are the risk factors associated with AF? We have genetic predisposition. We have age. The more the age, the more the higher incidence of AF. Hypertension is a risk factor. Heart failure, valvular heart disease, myocardial infarction, thyroid function. We know all hyperthyroidism, hypothyroidism, obesity with body mass index between 25 to 30, and obese. All these increase risk factors. Also, طبعا diabetes mellitus. Chronic obstructive pulmonary disease is also a risk factor for atrial fibrillation. obstructive sleep apnea is very high risk factor for, and sometimes patient will come, before we do ablation, we ask him to lose weight in order to minimize the risk and also to increase the success rate and prevent recurrence. If he doesn't go to decrease his body mass index, we don't do him. Chronic kidney disease is also a risk factor for AF. Smoking is a risk factor, even if he's a former smoker, but we encourage him to stop because the risk factor decreases. Alcohol consumption is also a risk factor for atrial fibrillation, and the exercise. The moderate exercise is a very good, not a risk factor, but increasing the vigorous exercise can increase the risk of AF. This is the statement by the European Heart Rhythm Association about the prevention of atrial fibrillation, and from conclusion from it, the primary prevention of AF is healthy weight, reducing alcohol intake, moderate physical activity, refrain from tobacco smoking, and also from the use of habitual drugs, intensive lifestyle changes, control of blood pressure, control of diabetes, treatment of obesity, and treatment of obstructive sleep apnea. Now we'll go to the treatment. The patient has AF, and we decided to give him an option for rhythmic control by intervention. What is the AF ablation? In the past, they did, and some people needed, pace and ablate. We have pulmonary vein isolation, and we have surgical ablation. Types of AF ablation: ablate and pace. This is AV nodal ablation and his bundle pacing, or RV pacing, or BiV pacing. In some cases, patients are in AF, permanent AF, very rapid ventricular rate, not controlled. Then the option or the solution is to ablate and pace, and better his bundle pacing or BiV pacing, better than RV pacing. This is encountered in patients with heart failure who received CRT-P or D, and they have very fast conduction of atrial fibrillation and not controlled, and the device is not working. Then you would go and do AV nodal ablation. Surgical ablation is the first ablation started by the linear maze, Cox maze procedure. Pulmonary vein ablation is the current situation with the catheter ablation using different types of energy, whether cryo energy, RF energy, or laser balloon energy. What does ablation do for these pulmonary veins? When we ablate the pulmonary veins by whatever energy we are using, we interrupt the re-entry pathway, we destroy the focal driving forces, we affect the sympathovagal balance through the ganglionic plexi, we improve heart rate variability, we reduce the left atrial size, and the success rate is not bad. It's 70 to 80%. Okay, the types of AF. Here we can see radio frequency current. This is heat delivered by a catheter around the ostium of the pulmonary vein or the antrum of the pulmonary vein, as I'm going to show. The cryoballoon is using the freezing energy in order to isolate these veins by freezing. The laser balloon is using the laser energy for isolation. The recommendation of the European Society of Cardiology for catheter ablation, it is class 1. It is indicated in patients with symptomatic paroxysmal AF to improve AF symptoms who have AF recurrence and they are tried antiarrhythmic medications and cannot tolerate it, and they prefer rhythm control. They can undergo this, and this is class 1 indication. Atrial flutter ablation during AF is a class 2A. While doing AF ablation, you do atrial flutter at the same time in order to avoid another session. Catheter ablation should be considered first-line therapy to prevent recurrent AF, improve symptoms in selected patients with paroxysmal AF as an alternative, and this is class 2A. AF ablation is considered in patients with symptomatic AF, heart failure, and those have reduced ejection fraction in order to improve symptoms and improve function, and this is class 2A. AF considered strategy to avoid pacemaker implantation in patients with Brady-Tachy syndrome. And this is 2A. Catheter ablation or surgical ablation should be considered in patients with symptomatic persistent or long-standing AF refractory to antiarrhythmic therapy to improve symptoms. Consider patient choice, benefit of risk, and supported by AF heart team. And this is class 2A for those with long-standing persistent AF or persistent AF. Regarding surgery, this is the last one. Minimally invasive surgery with epicardial pulmonary vein isolation should be considered in patients with symptomatic AF. When catheter ablation has failed, decision should be taken with the AF heart team. As I told you, ablation is a teamwork. Here I'm going to show some of the machines we use. We'll start by the radiofrequency ablation. The upper one are the Abbott radiofrequency ablator, the old version and the new version, and the lower one is the Stuttgart ablator, which is run by Biosense Webster, the old one, and the Smart Ablate one. This is the circular catheter which we use to map the pulmonary veins. The procedure starts by placing catheters, as you see, one in the choresinus, the big one looking to the left, the Hayes catheter, which looks to us, and then we introduce a sheath and a needle in order to cross the left atrium, the interatrial septum, and go to the left side. Then we place 2 sheaths through this puncture, or we do 2 punctures, and we crossed here the left atrium. You see the moving catheter is the ablation or the mapping catheter, mapping ablation catheter, getting signals going into the superior vein and the inferior vein, and the circular catheter is placed into the left superior pulmonary vein. Now we move to the right-sided veins. You can see that the moving catheter is negotiating the right superior pulmonary vein. The circular catheter is on the left superior pulmonary vein, and we are getting signals from this ablation catheter now going into the right inferior pulmonary vein. At the end, we got a picture, or we get a map. We get left atrial virtual map, as you can see here, with the 4 veins, the right on the right, the left on the left, and the appendage looking at us. And you can see the green one is the choresinus. When we place the circular catheter in the vein, we get the pulmonary vein potential, which are the potential firing of the sleeves around the pulmonary vein. As you can see here, we make magnification to it. These are firing spikes. These are the muscle sleeves around the pulmonary veins, which are firing foci, which fire many foci, go into the left atrium and initiate AF. We go after these pulmonary veins potential, and this is a delay while ablation, you can see, until we got rid of all these potentials. Not only this, but we do pacing from different poles of the circular catheter in order to see if these muscle fibers are working or not. And we can see here loss of capture, meaning that we isolated them completely. The cryoballoon for AF ablation consists of a console, and this console is using gas, nitrous oxide, and this is the catheter with a balloon in the middle, which delivers the gas and make the cooling through this balloon. And this is circular catheter is at the upper part of the balloon. I will show you everything. This is the sheath. This is the introduction sheath through which the balloon is delivered, and whole system is going to the left atrium. Here is the circular part with the poles to record PVPs, pulmonary vein potentials. This is how this catheter is connected to the machine and operated easily. It's a mobile machine. Here are the steps. After transeptal puncture, placing the sheath into the left atrium, we place the circular catheter, and then the balloon is inflated. We test that the balloon is completely isolating the vein, not by injecting contrast, and we look at any contrast coming out of the balloon. We'll see here through this cartoon video. This is the sheath, transeptal puncture. We go to the left atrium. Here are the orifices of the pulmonary vein. The catheter is introduced. This is, we call it the achieve. This is the circular catheter going inside the vein to record the potentials. And then here the potentials are recorded on the machine. Then the balloon is delivered. The balloon will be inflated, yes, and then will be pushed to the orifice of this vein in order to occlude it. When we make sure that the vein is occluded, we freeze, we make freezing, and this freezing will make ablation, will ablate the part of the muscle around it. Here we inject the dye to make sure there is no leakage of the balloon, and then the freezing is going down, as you see, on the temperature on the right side, and on the left side the potentials will here disappear completely. Very good. Then we deflate the balloon and withdraw the system from the body. Of course, before we deflate, we have to heat it, stop the, we can see the temperature is going up, balloon is deflated, and the system is withdrawn after going into all different veins. Here is an X-ray from one of our cases. As you see here, this is the achieve and the balloon and injection in order to make sure that the balloon is obstructing the vein and then cooling. We'll see this in a video from one of the cases at James University. This is the transeptal puncture, and we inject, yes, we inject dye. Now we inserted this sheath, the big sheath, and you can see the injection, the balloon is inflated, and we inject the contrast, now cooling with the machine, and the temperature is immediately measured, -30, -35, -50, and we have the timer, and we have the technician from the, we go to the right side veins, but we take the decapolar catheter to the right superior pulmonary vein in order to pace and make sure that the phrenic nerve is working. We pace to stimulate the phrenic nerve to avoid phrenic nerve damage from ablation of the right-sided veins by cryoballoon. The surgical ablation started by surgical maze procedure, and that was in Canada, started in Canada. And the indication of surgical maze, possibly via minimally invasive approach, is class 2, performed by an adequately trained operator in an experienced center, should be considered for an AF heart team, not only one, and for patients with symptomatic refractory persistent AF or after post-AF ablation to improve symptoms. Maze procedure, maze surgery, preferable by atrial surgery, should be considered in patients who will undergo cardiac surgery in order to improve their symptoms attributed to AF, and we have intelligent surgeons performing this while they do mitral valve replacement to minimize the risk of AF after surgery. And this is class 2A. Concomitant biatrial maze or pulmonary vein isolation can be considered in asymptomatic AF if he is going to undergo cardiac surgery. Why not to do it meanwhile? This is one of the tools, which is the Cobra probe, which surgeons use it in order to help them isolate the veins with open heart during open heart. This is one of the films. I like it very much because this is the Cobra, and these are the poles. It is connected to a ablator, a radiofrequency ablator, but special machine. And we can see the left atrium is opened, and the surgeon will show us how the left atrium will look. Look here. He is taking this machine around the pulmonary vein orifices, and the energy will be delivered. He has his assistant to take out blood from, of course, this is cardiac bypass. The heart is not on a pump, on a cardiopulmonary pump. Yes, this is the Cobra catheter. In Egypt, we had it for some time. And then we made an invention with the ablation catheter, the 8 millimeter, and the surgeon would put it with a clamp, and use it instead of this Cobra, and we run the RF machine with him. And this is a substitute in Egypt. We did it, many cases. This is a Cobra bipolar clamp, which can be used if the patient is not going to have open valve replacement, mitral. He can be used. This is, I didn't see it before, but this is a cartoon showing that it can be done with the surgery from outside the heart, instead of doing incision, he's doing this probe in order to get the lines of maze, like this, yes. We have to decrease the risk of stroke in AF management. And we all know the role of anticoagulation and the role of the novel oral anticoagulation. And there will be a special chapter in this education given by my colleagues. However, I'm going to show you the left atrial appendage occlusion in those patients who are not candidate for oral anticoagulation, who have bleeding diathesis, who have contraindication to oral anticoagulation, and we have to manage their left atrial appendage, which is the source of thrombi. Therefore, these patients will need a left atrial occlusive device. And according to the guidelines, it is a class 2B indication in those patients to prevent stroke in those who have life-threatening bleeding from the oral anticoagulant. This left atrial occlusive device, there are different types, and one of them is introduced through transeptal puncture into the left atrial appendage, and it is inflated. Those who do these devices for ASCD occlusion understand this very well. Of course, transesophageal echo during the procedure is needed in order to measure the diameter of the left atrial appendage and the shape of the left atrial appendage, and to choose the proper size of the device to occlude it. This is a video which explains how this procedure is done. And as we see from this diagram, this is the transeptal puncture, where the sheath and the dilator is introduced. Then the pigtail catheter is introduced into the left atrial appendage in order to inject it and to get to the size. Then the device is delivered, as we can see here from this video, and ensured that it is tucked and is stable in position. And then the introduction set is withdrawn. Here is the shape of this umbrella, our occlusive device, to see how it is introduced and how the device, as you see here, this is the tucking mechanism in order to know that it is stable in position. The patient will need anticoagulation for some time until there is a complete endothelialization of this occlusive device towards the left atrium. However, there are some publications that it is not completely secure and there are some blood coming out. But still, this is the only option for those who cannot receive oral anticoagulation. This is the Watchman device. Thank you very much. This is my team. I hope that you enjoyed it.